You can start, Dr. Balian. Perfect.
Everybody, this is Dr. Harry Balian. I am an interventional cardiologist specializing on structural heart disease and peripheral vascular disease, as well as in complex coronary interventions. I practice out of multiple hospitals, main one being Adventist Health Glendale, as well as USC Vertigo Hills. I've been the chair of the cardiology department here at Adventist Health Glendale since 2015, and then the director of the cath lab since 2007. So today I want to talk about percutaneous treatments in structural heart, the latest updates, and some new data, new developments that have come on over the last 6 months to a year, which I would like to share with you. So I have no financial disclosures. So my objectives are as follows. I'm going to talk about aortic valve disease. As you know, that's one of the 4 valves of the heart. Signs and symptoms of AS. We're going to talk about percutaneous replacement of the aortic valve, namely the TAVR. Then we're going to switch gears and talk about the second valve, which is the mitral valve that separates the left atrium from the left ventricle. Talk about the different ways that the mitral valve degenerates and it causes regurgitation of the valve, and namely primary MR and functional MR, which is secondary MR. Talk about treatments of mitral valve regurgitation, namely percutaneous treatments and the mitral clip. And then now we also have the capability of replacing the mitral valve percutaneously, just like we replaced the aortic valve percutaneously. Then I'm going to switch gears and talk about the tricuspid valves that separates the right atrium from the right ventricle. Signs and symptoms of severe TR, and then percutaneous treatments of TR, namely based with the tricuspid valve clipping, and also the tricuspid valve replacement percutaneously. Lastly, I want to say a couple of words about the Watchman device, its indication and procedural methods, and final remarks. The aortic valve is basically the valve that separates the left ventricle from the body. It's the last valve through which blood exits from the ventricle. It goes through a lot of wear and tear during someone's lifespan, and needless to say, aortic valve develops calcium on its leaflets, and patient develop what's called aortic stenosis. When aortic valve becomes stenotic, the left ventricle has to work extra hard to squeeze blood through that orifice, and the more narrow the orifice gets, the more pressure it puts on the left ventricle, which eventually becomes hypertrophied and then becomes basically lax, and the patient can develop cardiomyopathy. So looking at the overall valvular stenosis, normal valve area should be more than 2 centimeters squared. If somebody has mild AS, the valve area is between 1.5 to 2 centimeters squared. The moderate is 1 to 1.5, and severe is less than 1 centimeter squared, and critical is less than 0.7 centimeters squared. When somebody has symptoms syncope, angina, and CHF symptoms, they have severe AS, those patients need to be strongly considered for valve replacement. There are some anomalies where patients at their younger ages can develop aortic stenosis, and those are patients that have congenital valvular anomaly, such as the ones that have either 1 leaflet or 2, like bicuspid valve. Normally, aortic valve has 3 leaflets. Patients with bicuspid aortic valve are most commonly developing symptoms, actually murmur in their 30s, and symptoms by the time they're in their 50s, requiring valve replacement probably in their late 50s to early 60s. But the most common the form that the aortic valve progresses, aortic valve stenosis, is what's called the senile AS, where people get aortic stenosis as they get older. In fact, 80% of patients in their 80s have some level of aortic stenosis. So looking at some of the symptoms of AS, shortness of breath, syncope, angina, fatigue, difficulty when exercising, and then also bipedal edema. So a lot of the signs and symptoms of heart failure. So when you look at the aortic valve, as I mentioned, the aortic valve is the last valve through which blood exits. This is the left ventricle. Basically, when you have aortic stenosis, you have decreased blood flowing through the aortic valve and decreased blood sitting in the aortic ascending aorta. As we know, during diastole is when the coronary arteries get their blood flow and the heart muscle gets its nourishment during diastole. Now, when you have little blood flow exiting the heart, your diastolic pressures can be low. You also have decreased filling of the left ventricle. And with time, because the heart is pushing so hard, it's going to get hypertrophied. So with the hypertrophied ventricle, you're going to have increased oxygen demand, and then you will definitely have a mismatch between oxygen supply and demand as you have decreased perfusion to the coronaries, and then now you have a thicker heart muscle that the heart needs to survive. So because of the O2 mismatch between supply and the demand, you basically have heart failure. So when people develop heart failure with the aortic stenosis, their survival is basically in 2 years, 50% die. So you have this mnemonic SAD, SAD, syncope, 50% are dead in 5 years. Angina, where you have chest pain with severe to critical AS, 50% are dead in 3 years. And then when you have heart failure, 50% die in 2 years. So when you look at this diagram, when somebody has severe aortic stenosis, and the definition of that is aortic valve area less than 1, and the Vmax, the velocity across the aortic valve is more than 4 meters per second. If somebody's going to have open heart surgery and they have severe AS, they should have valve replacement as well. If basically they have symptoms, that's it. And with severe AS, they need to have valve replacement. If their symptoms are equivocal, then we can do low-level stress test. If they drop their blood pressure, that's a red flag, class 2B indication for valve replacement. If they have normal ejection fraction with equivocal symptoms, and then you basically then follow them and the EF starts dropping, that's a time that they need to have valve replacements. Otherwise, if somebody's asymptomatic, truly asymptomatic, you have to follow them, do serial echoes and see if their EF drops. Even so low-level exercise, if it does not elicit symptoms, then you can still watch, you put them on statins, beta blockers, and then watch. You have to be very cautious to make sure that these patients with severe AS do not have overt reduction of their afterload, such as being placed on high-dose ACE inhibitors, because that actually causes them to get sicker. When you drop their afterload, the heart's already pumping against great resistance with the aortic stenosis, then they can actually decompensate, and then they have even poorer perfusion to their coronaries and their heart. So when you have an aortic stenosis, or when you hear a loud murmur in the patient, which is actually in the right upper sternal border, crescendo to crescendo murmur radiating to the carotids, you have to do an echocardiogram, and then that actually will tell you the patient's valve area is narrowed, and also you can check the gradient across the aortic valve. And then of course, once we determine a patient has severe AS, then we need to do a coronary evaluation, because we want to make sure that coronaries are intact before we make any kind of plans for surgical or percutaneous valve treatment. So unfortunately, there's a high number of patients walking around with aortic stenosis, and however, very few of them that actually get a treatment. So 1.6 million diagnosed, and then only about 18,000 of those get actual TAVR, which is valve replacements. The aortic stenosis severe has a worse prognosis than a lot of the metastatic cancers. So we tend to focus so much on the cancers, which we should, but we tend to sort of under-treat and under-recognize the impact of severe AS on patients. Severe inoperable AS has worse prognosis than a lot of the cancers. This is a landmark sort of an article. First, it brought the percutaneous valve treatment in the light spotlight. Basically, it highlighted the actual valve, which is navigated over a wire percutaneously across the stenotic aortic valve, and then the valve is undermounted on a balloon and it's inflated, and subsequently a patient has a new aortic valve, and the old valve leaflets are crushed across the new stent valve that is placed. This is the Evolute Medtronic valve, which is a self-expanding one. whereas the Edwards one is the balloon expandable one. So this is patient that's having the self-expanding aortic valve, which is basically being deployed. And after that, after deployment, you see that there's the high gradient between the aorta and the left ventricle is diminished or disappeared because now the flow in the left ventricle, the pressures rather, is the same as what the pressures are in the aorta. So the result of that article, 86 patients, device was successful, and the stroke rate was actually low, but now it's actually been even lower. The partner trial was a landmark trial that brought the TAVR valve in the market. And basically, it looked at patients, comparing them between SAVR, which is a standard aortic valve replacement, versus the TAVR. And it was published in 2010, and there have been multiple series of this, a 1-year follow-up, 3-year follow-up, and 5-year follow-up. Basically, it showed that standard therapy, which is the SAVR, where you have a surgical valve replacement, had a higher death from any cause versus the TAVR. So also, basically, the death from cardiac causes were lower, death from repeat hospitalizations were lower with SAVR, and death from major strokes were also lower. As far as the quality of life, patients that had a baseline TAVR versus the standard SAVR, a lot of them were sitting in class 4. Once they got the TAVR in 30 days, their NYHA class was reduced from class 4 to 3 and then 2. And then this was actually persistent. Then these numbers were persistent at 6 months and also 1 year, meaning TAVR was just as favorable in reducing patients' NYHA class and their heart failure status as the SAVR. Looking at this diagram, you see that with the TAVR, you have lower repeat hospitalizations, lower death from any cause. You have a slightly higher chance of strokes, minor and major. And this was more prevalent in the older, bulkier devices because you're actually navigating a bulky device through the aorta, and you can sprinkle some of the calcium up and across into the brain. But as we've gone the device more manageable, and we've gone more and more, we have raised our expertise level. We actually are able to minimize the strokes, and the stroke numbers are actually better. As far as bleeding, since we have percutaneous access, the bleeding rates are higher than the SAVR, and even that, those numbers have dramatically come down as we're able to navigate these large devices and be able to percutaneously seal the groin at the end of the procedures. I do multiple TAVRs a week. I did actually 3 today, and we're able to seal the hole in the groin by putting a perclose stitch internally and also an angioseal. And that in itself actually takes care of the hole that we made in the artery. And at the end of the procedure, which lasts about an hour, and the patient goes to the recovery room and then subsequently goes to telemetry bed, and they're home the next morning, which is much different than when somebody undergoing SAVR open heart surgery, where they're having their chest cracked open and they're having a cardioplegia, cardiac arrest. The valve is taken out and then the new valve is sutured in. The hospitalization in those patients is definitely more than 1 day. So the history of TAVR, at first 2002 in Europe, Dr. Cribier is the first implanter of this device. Since then, we've had a number of reiterations and improvements of this valve, and we have basically have had the core valve approval, then Edward Sapien in 2008, and subsequently the partner trial 2010, bringing the TAVR valve in the market, and multiple centers have essentially been using it all across the world. So when you look at an aortic stenosis, you can have the traditional severe aortic stenosis with a high gradient. You can have a severe aortic stenosis with a low flow, low gradient. And those patients are actually important to recognize, because sometimes we can have a low valve area, but the gradient may not be across the valve, may not be as pronounced. But those are patients that have a low ejection fraction and they have actually a weak heart, and they're not able to pump blood efficiently across the valve. And so the gradient that we're looking at across the aortic valve is actually low, but in fact it is, if the heart pump was actually pumping more briskly, the gradient would be high. In those patients, what we do is we actually bring them in and we infuse a low dose dobutamine and get increase the inotropic forces of the left ventricle. And once the LV is contracting more forcefully, the gradient across the valve actually is then pronounced, and we're able to see that the gradient is much higher than what the regular traditional echo is showing. So this is the paradoxical low flow, low gradient AS, which we have to make sure that we don't miss, because just looking at the numbers sometimes is not enough. You have to sort of incorporate the fact that some people have weak hearts and they're not able to pump briskly, and the gradient may be mistakenly low. So the TAVR Edwards valve SAPIEN 3 showed that the disabling stroke was 1% per year and then 1.1% mortality. It was 75% lower than the SAVR, which is the traditional surgery. Now, when we have a patient that we identify for TAVR, it's a collaborative effort. I preside the TAVR committee at Adventist, and I started the TAVR at Glendale Adventist Hospital 2016. So over the last 6 years, we've done countless number of TAVRs, but every single patient first is identified, then is worked up, and subsequently we're able to then meet in the TAVR committee and go over their films and be able to sort of outline whether this patient is a candidate for TAVR or candidate for SAVR or no candidate at all, just medical management. After that, we basically then patient already has gone through multiple tests, namely a CT angiogram of the chest, abdomen, and pelvis, which gives us a roadmap of the body, of their vasculature, and we're able to identify which side of the groin we have to put our big sheath in to navigate the TAVR valve. And sometimes we have run into obstacles where patients' groin and vasculature is so poor that we have to look for alternative access, such as a subclavian artery, or doing a direct apical stick of the heart, sticking the heart directly at the apex and delivering the TAVR valve that way. So again, this is a team approach. We have to systematically develop a collaborative approach to be able to look at our heart team and have them discuss the patient and make a decision. So the TAVR patients represent, severe symptomatic TAVR patients. They can have a history of strokes, reduced ejection fraction, prior open heart surgery, history of atrial fibrillation, prior open chest surgery. They also are inevitably very fatigued and they have a slow gait. They can have peripheral vascular disease, multiple comorbidities as outlined above. Now, the actual approaches where we can go through through the groin, which is the most traditional. If that's not an option, we can go directly to the apex, or we can do subclavian access and navigate the valve directly that way. So again, this is a transfemoral approach where we go to the groin. Transapical, we stick the apex directly, or the subclavian or transaortic approach, we go to the subclavian artery. So, and I cannot emphasize enough that this is a multidisciplinary approach. It's not just one team. It comprises of the interventional cardiologist, the surgeon, the TAVR coordinator, and basically multiple people sort of working together to make this happen for the patient as far as the TAVR scheduling and the procedure. So the Dr. Cribier was the first implanter of the TAVR device in 2002. 150,000 patients have been treated worldwide and 50,000 patients in the United States, and treating patients in over 65 countries. There was a significant reduction in mortality for the inoperable patients with the SAPIEN valve versus the standard therapy, and a significant rehospitalization drop with the TAVR patients versus standard therapy. Mortality also has continued to decline as we've sort of implanted more and more of the Edwards TAVR valves, and the stroke rate also continues to decline. Survival in high risk and inoperable patients, there's an excellent 30-day outcome and also 1 year. This is basically the partner trial, and then they basically looked at the SAVR versus the TAVR patients and outlined their overall stroke rate and also their hospitalization rate. So all-cause mortality was lower, 1% for the TAVR group versus 4% in the SAVR. The disabling stroke was 1% versus 4.4 TAVR versus SAVR. This is a sapien valve. Basically, it's a bovine valve that's mounted inside the stent strut, and this stent itself is actually delivered. It's crimped on a balloon. It's delivered across the aortic valve, and the heart rate is raised to about 180, where the LV is disabled. Otherwise, it would contract and the valve would embolize. So we disable the LV by making it beat so fast that it stuns the LV and basically almost like patients having a fibrillation. And then we're able to deploy the valve successfully, and then we basically then undo or disconnect the pacemaker, temporary pacemaker, and the heart beats are back to normalcy. So basically looking at the range of the sizes of the valves, and it goes from the smaller patients, 20 versus 23, 26, and 29. It just sort of depends on the diameter of the aortic valve. So again, these are the numbers of patients, even an intermediate and high risk. The transcatheter aortic valve was much better than the open, or as well as the SAVR. So this is a patient that we took care of, 81 years old, multiple comorbidities, severe AS. We discussed with the heart team, and as patients saw 2 surgeons, and now we've actually reduced that number to only 1 surgeon. We don't need to have 2 surgeons see the patient. So EKG looks basically showing a borderline aortic progression. The coronaries were fair. There's maybe a borderline region in the LAD. The valve area 0.59, meaning they have critical AS with a mean gradient of 54. Echo is then again outlining the severity of the AS. They're highly calcified leaflets. This is the aortic valve. This is the mitral valve. So we measured in a CT angiogram the diameter of the aortic valve at 446, which puts us at a comfortable 26 millimeter TAVR valve, and we basically were able to do a CT angiogram of patient's anatomy, and we know that we saw that the patient has significant calcification throughout the femoral and iliacs, and hence we chose to do a non-traditional approach where the patient had actually a TAVR down to the apex. We actually had a mini incision, mini thoracotomy, and then we stuck the heart directly, delivered the valve backwards into the aortic valve. Patient did well. Because of the thoracotomy, had to stay in the hospital 3 additional days and then went home. But normal TAVR procedures, patient usually are discharged the following morning. So again, this is the heart. This is the LV that we stuck in the apex, and then we went backwards and delivered our TAVR. So now I'm going to switch focus to the mitral valve. This is the valve that separates the left atrium from the left ventricle. I'm going to define the anatomy and talk about etiology, signs and symptoms, outline new treatments of modalities of MR, COAPT trial. I'm going to talk about the mitral clip, and I'm also going to talk about the TMVR, which is the percutaneous mitral valve replacement. This is the new frontier. Previously, we were able to treat mitral valves via medically, of course, and then also the mitral clip. And now we're able to change the mitral valve just like we do with the TAVR. We're able to insert a new valve across the old one and basically replace the mitral valve percutaneously without cutting the chest open. So this is the mitral valve in a cartoon. When you look at this mitral valve, this is basically the left atrium and then the left ventricle, and you're looking at the anterior leaflet and the posterior leaflet. If you're looking at the heart from posterior to anterior, let's say this is the back wall, and then the first half of the mitral valve leaflet is called the posterior leaflet, and then the second half is called the anterior leaflet. And then the mitral valve itself is divided into 3 portions. As far as the accomplishers, A1, A2, A3, and P1, P2, P3. Sometimes when we look at the mitral valve, we have to see how the valve leaflets collapse, and sometimes you can have actually what's called primary MR, where the mitral valve leaflets are degenerative because they're flail, or they have mitral valve prolapse with a regurgitation. Or we have functional or secondary MR where the patient has cardiomyopathy, the heart muscle is enlarged and stretched, and then the valve leaflets themselves are also not coacting well. So looking at the anatomy again, looking at the heart from top down, and this is the posterior wall, this is the anterior wall. We have the mitral valve, which is tricuspid valve, and aortic valve. And then essentially, we have the mitral valve, the circumflex artery basically wraps around the mitral valve annulus. And sometimes these patients can have mitral regurgitation because they have inadequate blood flow through their circumflex artery. But this is what's called ischemic MR. Again, this is another view of the mitral valve. This is the posterior leaflet, and this is the anterior leaflet. This is the posterior wall of the heart, and this is the anterior wall. And this is the right side of the heart, SVC and IVC. And again, we're looking at the actual pictures. Again, I just want to orient you. This is the lateral of the heart. This is left atrial appendage. This is the actual intra-atrial septum and the fossa, and then this is where the right atrium would sit. This is the left atrium, and then this would be like the A1, A2, A3, and then P1, P2, P3. So Dr. Carpentier was a French thoracic surgeon, and he did a lot of work on identifying the mitral valve, and he actually has Carpentier's functional classification. Patients with a normal valve have type 1, normal leaflet motion. With excess leaflet motion, they have a type 2, Carpentier. Type 3 is the restricted leaflet motion, and the 3A or 3B. So this is the different kinds of patients with mitral valvular regurgitation. So this is, you can have, when you do the TE, you see the actual jet escaping as the two leaflets are not coacted properly. You have a severe central MR. So patients with MR, they're going to have symptoms of shortness of breath, palpitations, and AFib, fatigue, lightheadedness, cough, and this is a progressive disease. I already mentioned about the primary MR, which is the degenerative, and also the functional MR. So the primary MR, normally the heart function is normal, but the valve leaflets are not. You can have a mitral valve prolapse that has essentially degenerated into severe MR. Secondary MR is a functional MR in patients with cardiomyopathy. They have actually such enlarged heart, and mitral annulus is enlarged, and patients can develop mitral regurgitation. So these are the stages of chronic primary MR. Looking at risk for MR, looking at the mild mitral valve prolapse versus somebody with severe symptomatic MR. They have severe mitral valve prolapse with loss of coaptation. They can also have rheumatic valve changes with leaflet restriction. Those are the patients that need to be definitely looked at and treated, whether it's percutaneously or with valve replacement. As far as the actual parameters, looking at the parameters, we can do qualitative mitral valve morphology, mild, moderate, or severe. Then you can look at the MR color jet. You can look at the quantitative regurgitant volume. If the volume itself is more than 60 ml, that's severe. You can look at the regurgitant fraction and calculate that. And you can also look at what's called the ERO, which is a regurgitant orifice. And if it's more than 0.4, it's classified as severe MR. It's important to note that patients, as they get older, their valves degenerate. It's just like any other part of the body. And patients in their 70s and above, they have a higher chance of having all kinds of valve disease, especially MR and aortic valve disease. So the MR progresses eventually to heart failure. That's why it's important to recognize this and treat it early rather than letting the heart enlarge and fail, where a patient becomes a cardiac cripple and inoperable. So the heart failure, of course, we know that it's a big burden to the healthcare and economic burden. And of course, patients that come in with a heart failure, BRG, within the first 30 days of readmission, of discharge rather, the Medicare does not reimburse the hospital, and that's a big cost that hospitals eat out of their pockets. So the severe MR leads to increased hospitalization because of leads to increased morbidity, and heart failure recurrence. And the MR, unfortunately, is under-recognized, under-treated, just like the AS. Total MR, 4.1 million patients eligible for the MR treatment, percutaneous or surgery, 1.7 million. And eventually also only 30,000 get the actual surgery or the treatment. So it's very parallel to the aortic stenosis. So in this situation, primary MR, the risk for unsuccessful repair, if you have a large central jet and annulus is dilated, you have involvement of greater than or equal to 3 scallops, especially the anterior leaflet. So also, if you have extensive calcification, that's also a stop sign for a mitral clip. I had a patient a couple of weeks ago that has severe MR, and we actually looked at the patient and we thought she qualified for the mitral clipping. And when we brought her in, we did our 3D TE and we saw that she has severe mitral annular calcification. We essentially aborted the case simply because if we're down in the mitral valve, below the mitral valve and grabbing the leaflets, there's a chance that we can grab onto the calcium that the leaflet is surrounded with, and we can embolize a chunk of the calcium to the brain. So the mitral clip consists of percutaneously delivered MRI compatible cobalt chromium implant, 2 arms, and then also on the inner portion of the clip are U-shaped grippers. It's almost like a sandwich. You deliver this kind of an airplane device. The wings are not fully open. Down across the mitral valve, then you open the wings, and then the grippers, which is the upper, which is above the actual clip, are dropped, and then it grabs on to the leaflets, and then you basically then close the clip, and the clip itself becomes like imagine the pliers, you're closing them, and then you're gripping on the mitral valve leaflets. So this is basically the actual clip device. We navigate this across the intra-atrial septum to the left atrium. We open partially the clip wings, and this is the grippers. We advance this across the mitral valve, and then we line it up so it's sitting right where the regurgitation is, and then we drop the grippers, so now the valve leaflets are sandwiched between the grippers and the actual mitral clip. Then we close the mitral clip tight, and then we assess the actual mitral valve regurgitation. We also pay close attention to the mitral valve gradient. There are times where when we put a clip and close the clip, we can actually make the valve too tight, and then we can create a separate disease process where a patient goes from severe mitral regurgitation to severe mitral stenosis. So this is a patient, this is a 3D view. This is the mitral valve, the posterior leaflet, and the anterior leaflet. And then you see the central jet. This is where the clip has been placed at the A2P2 level. And this is basically taking care of the central jet as we're seeing here. So mitral clip therapy, medical therapy such as afterload reduction, ACE inhibitors, ARBs, etc. And then that's less invasive, and then the increase MR reduction, we can do the mitral clip, and that actually reduces the mitral regurgitation. Then it's a mitral valve surgery, open versus the percutaneous, where you can actually replace the mitral valve. So the development of the mitral clip dates to 1998. Frederick Sangor started experimenting with the percutaneous techniques of the NDR. So the feasibility was first studied in animal model, of course. In 2003 June, Dr. Jose Condado in Venezuela was the first implanter in a 48-year-old woman with severe MR. So since then, we've had significant advancements in the mitral clip and its overall device and the deployment. Now looking at the actual indications for mitral clip, as the risk of surgery is high, and the anatomy for the anatomy for mitral clip is basically complex. So the patients, if the anatomy is simple, the risk for surgery is high. It's a slam dunk for mitral clip. If the risk for surgery is low and the anatomy is complex, those patients should be sent to surgery. So the happy medium is that if you have a high risk for surgery, and then you can also have a complex anatomy, you can still clip those patients and they do okay. So different etiologies of mitral regurgitation is where they can have ischemic MR, as I mentioned. So mitral valve or circumflex artery is ischemic. or has a plaque and you have inadequate flow through the circumflex, then you can have MR. Endocarditis with valve infection, they can have residual MR. Rheumatic valve disease, and then and of course the most common is degenerative or primary MR with mitral valve prolapse. 65% of patients with MR have that. So with the mitral regurgitation, now you have basically this valve separating the left atrium from the left ventricle. When you have the mitral valve that is not fully closing, as the LV contracts, half of the blood goes to the aorta, to the body, head and lower body. The other half goes back to the left atrium. That puts added pressure in the left atrium and then also the pulmonary veins. And of course, the pulmonary venous system is heavily congested, and patients then develop heart failure and pulmonary edema. And in time, as you have enlargement of the left atrium, mostly about 4.5 cm, that actually predisposes patients to go into atrial fibrillation. And a lot of the MR patients with left atrial enlargement also have atrial fibrillation. So this is a transthoracic echo. You see the LV here, and in the left atrium, you have a severe MR with a jet hitting all the way to the back wall of the left atrium. This is the clip as I showed you earlier, and these are the grippers. Once we advance the clip across the mitral valve, we open the wings of the clip, and then we drop the grippers, and this actually sandwiches the valve leaflets. And then we close the overall clip, and then we're able to assess the mitral valve gradient. If we're happy, then we release the clip and we undo, and then we get this delivery device out of the bottle. So this is basically the cartoon of the mitral valve, the actual clip going across the mitral valve, and then the clip is deployed, and you see the ellipsoid mitral valve now looks like an alien eyes. This is a true figure of eights. So impact of mitral regurgitation as an MR is malignant, independent predictor of mortality. 1 year mortality with severe MR is up to 57%, and we tend to under-recognize that. So mitral clip evidence, we actually studied 16 plus years of the mitral clip itself in development, and we're able to look at the COAP trial, which is a landmark trial that looked at MR severity. So patients with severe MR, primary MR, at baseline and upon discharge, they actually had, after patients had the mitral valve clipping, overall their lifestyle got better, their NYHA class got better, their rehospitalizations got better. So again, you see that there's an NYHA class going from class 3 to class 2 to class 1. So more patients were actually in class 2 and 1 than class 3 after they received the mitral clip. So the COAP trial randomized mitral clip plus guideline-directed medical therapy versus guideline-directed medical therapy alone. 600 plus patients. Half of the patients had heart failure with preserved EF, and half had heart failure with reduced EF. So overall, there was a 38% relative risk reduction in mortality, and the number needed to treat was 5.9. There was also 33% relative risk reduction in mortality, and the number needed to treat was 7.9. And those patients are looking at all-cause mortality. So as far as the mitral clip has become very standard, and we take care of those patients with primary MR and functional MR almost routinely. We do about 2 to 3 a week. I have 2 coming up actually on Thursday. So again, the mitral clip MR is a cause of death. A COAP trial showed that MR is not just a marker. Mitral clip is the only mitral valve device to improve the survival of heart failure in patients with secondary MR. Those are the patients that have decreased ejection fraction and have mitral regurgitation. So MR severity is not just one number, but it requires an integrative approach. And and to assess the severity of the MR, the COAP trial basically showed significant reduction in morbidity and also NYHA class and recurrence of repeat hospitalization in patients that received the mitral clip versus just simple guideline-directed medical therapy. So looking at the overall how the procedure is done, we bring the patient to the cath lab. We actually have intubated the patient. We've inserted a TE probe, and this TE has a 3D capability. We do a venous puncture in the groin. We do pre-close, we deliver a stitch but not cinch it. And basically, we deliver, we advance the wire, then do our transeptal puncture. Then we're able to actually show you here. So this is a TE showing the bicable view where we look at the right atrium and then the left atrium. This is where the wall is. We're able to actually go across and puncture the septum and make sure that we have enough of a height from the mitral valve. We want to make sure we're actually at least 4.5 millimeters above the mitral valve. And here we're doing the transeptal puncture and going across the intra-atrial septum. And basically, once we do the transeptal puncture, as I said, I think I said 4.5 millimeters, 4.5 centimeters. So we want to make sure we're at least 4.5 centimeters above the mitral valve leaflets to have adequate height to deliver our device and then deliver the clip across the mitral valve. So once we do that, then we're able to do the transeptal puncture, put the wire, then put the sheath across and navigate this, looks like a rocket launcher. We navigate this device across, the actual clip across into the left atrium, across the mitral valve, and then subsequently, this is the device and this is the mitral clip. We deliver it across the mitral valve and line it where we wanted to, open the clips and then drop the grippers, and then eventually close the clip. There's a clip, and then deliver the clip, and therefore reducing the actual mitral regurgitation. This is the picture of the mitral clip below the mitral valve, and then basically we're trying to grab the two leaflets, and then here we are, we grab the two leaflets and we're closing the clip, and then delivered it, and then the very prominent V wave, which is consistent with severe MR pre-clip versus post-clip. The V wave amplitude is much lower, means the mitral regurgitation is essentially wiped out. Now, further treatments with aside from the mitral clip have been percutaneous annuloplasties. So a lot of theory has gone to say, why do we have mitral regurg? Sometimes the leaflets are intact, but the actual ring, the annular ring, is actually widened, and that's why the leaflets do not clap properly. So we can actually percutaneously access going to the coronary sinus, and then percutaneously put a ring across the coronary sinus, and therefore bringing the two leaflets together. This is the one example of the Monarch. This is the Edwards Life Sciences. It's a two-anchor design with chronic reshaping. There's other ones, a Balian and then PTMA. So the Monarch, it's basically self-expanding anchor, a spring-like bridge, and it basically causes the annulus of the mitral valve to be smaller and the mitral valve regurgitation, the functional MR, to be better. So this is, again, you're going across the coronary sinus, which wraps around the mitral valve, and you're delivering this device percutaneously and then making this annulus smaller. The Percutaneous device is similar, going across to the coronary sinus and then delivering this device. And again, different methods of doing this. So now jumping to percutaneous mitral valve replacement, which is basically the next frontier, the new frontier. This is a stent valve, and it's been challenging to really perfect this. The TAVR has been simpler, easier, because the aortic valve is circular, whereas the mitral valve is ellipsoid shaped. Plus, the mitral valve has the chordae, the little strings that attach the valve leaflet. So if there are times where actual deployment of the valve, we interact and get across the chordae, and that can be an impediment. Also, being able to land the valve accurately is challenging because the valve, as I mentioned, is ellipsoid. It's not circular like the aortic valve. So again, mitral valve, the positioning, the valve sealing, proximity to the left ventricular outflow tract, complex anatomy, and delivery system, all of those have been challenged. So looking at the different kinds of valves that are out there, the most commonly is the Edwards valve. Basically, this is the one that anchors in the left atrium and then goes across the mitral valve. So looking at the Cardia Q Edwards, this is circular, nitinol, self-expandable, and mitral annulus capture with native leaflet engagement. It's a tri-leaflet bovine pericardium valve. just like the TAVR valve. So looking at the actual different kinds there, this is the AccuFit. Cardio valve is this one, and Cephia, Saturn. All of those are sort of you know the ones that potentially are available for mitral valve replacement, but most commonly used the cardio valve with the Edwards. The cardio valve, self-expanding 9-hole frame, 3-leaflet bovine, as I mentioned, does not use radial force, and 2 sets of anchors grasping the mitral valve leaflets from left atrium and left ventricle side. It's used for fixation. So this is basically a picture. We'll go to the groin in the right atrium, go across into the left atrium, and then basically you have the 2 anchors anchoring below the valve, and then you deploy the valve. And part of it is sitting in the left atrium, and the valve itself is right between the left atrium and the left ventricle. The tiara again is a neovasc from British Columbia, self-expanding, and crossing with bovine pericardial tissue. It's in atrial position, specifically fits the saddle-shaped annulus, and 3 anchoring structures, and 2 anterior and 1 posterior. This is again you see the atrial skirt, and then you have the actual valve, bovine, and then we have the actual anchoring system. This is the valve looking at top down. And this is the actual deployment of the valve, where you actually have part of it sitting on the left atrium, and then the other part is actually anchored in the left ventricle. These are the actual anchors, and then the valve is in the middle. So as far as the valves, the more valves we deploy, there's a chance that we can develop what's called perivalvular leak, where you have a gap between the actual the deployed valve and the tissue of the heart. And those are problematic because it can develop to hemolysis. It can cause heart failure, so they have to be closed. And we can actually advance an actual catheter across the valve, and we're able to deploy these little mini plugs, and we can actually seal the leaks with the plugs, and then those are the actual perivalvular occluder devices. So let me direct my attention now to the tricuspid valve. This is the valve that divides the right atrium from the right ventricle. Tricuspid regurg is a big problem. It leads to significant morbidity and mortality. So let me describe the anatomy, the etiology, signs and symptoms, and the treatment modality. So this is basically the tricuspid valve. It's much more complex and harder to clip than the mitral valve. You have the anterior leaflet, posterior leaflet, and the septal leaflet. It's a tri-leaflet, whereas the mitral valve is bi-leaflet. And looking at the actual anatomy, you have the anterior leaflet, septal, and the posterior leaflet. You do have the coronary sinus here. You have essentially it's more of a complex structure. It's as I mentioned, tricuspid valve separates the right atrium from the right ventricle, and it's a tri-leaflet anchored by chordae tendineae onto papillary muscles of the right ventricle. Tricuspid regurg causes increased size of the RV, and hypertension, cardiomyopathy, left-sided failure can cause these. Epstein's anomaly is a malformed tricuspid valve leaflet. It's lower than the normal in the RV, and other causes of TR: infected endocarditis, carcinoid syndrome, tumors in the digestive system causing subsequent damage of the pulmonic and tricuspid valve leaflets. Pacemaker leads traditionally have been a big, sort of a bad actor in causing TR, because the leads are across the tricuspid valve, eventually cause degeneration of the valve, and the valve leaflets do not close. So now we have the actually leadless pacemakers, where we implant them directly into the RV and patient, and the ICD subcutaneous, where it's on the sidewall of the chest, outside of the ribs. So there's no leads involved, and that way we don't chance damaging the tricuspid valve. Endomyocardial biopsy for transplant patients also can cause TR. So blunt chest trauma, rheumatic fever, congenital heart defects such as ASD, VSD, Epstein's anomaly, Marfan's, radiation to the chest, all of them can cause TR. So the risk factors: endocarditis, cardiomyopathy, pulmonary hypertension, are right-sided MI. All of those are risk factors to develop TR. So diagnosis, signs and symptoms: EKG showing tall P waves in V2. Those are called the Himalayan P waves. And an echo showing right ventricular enlargement and TR. The cardiac MR shows RV enlargement and tricuspid valve pathology. And of course, the chest X-ray shows a very pronounced right-sided cardiac silhouette. So this is the EKG when a patient with right-sided or severe TR. You have the Himalayan P waves, tall peaked P wave in lead 2, and also upright P wave in lead V1. You have the RV straining here. You have basically the sort of the T wave flipping from V1, V2, V3. This is a pronounced R wave. This is classic RVH. The cardiac silhouette is very pronounced. This is the right ventricle, very much enlarged. This is the left ventricle. It's actually normal size. It's occupying half of the left side of chest. The actual echo shows an enlarged right ventricle, and then you have what's called a D-shaped septum because you have a volume overload in the short axis view. The left ventricle is squished and looks like a D, and our right ventricle is huge. So there's different treatment modalities of the tricuspid valve, just like there is on the mitral and aortic. So my tricuspid valve can have annuloplasty performed, direct ring annuloplasty, coaptation with the actual clipping, and then now we also have capability of doing a tricuspid valve replacement, just as we do with the mitral valve and aortic valve. So the insertion of the transcatheter procedures, it's the same sort of a format using the same platform as the mitral clip, except we sort of use what's called a reverse key. We actually sort of, instead of going through the left atrium and mitral valve, we're going through the right atrium to the tricuspid valve. So here's a clip going to the tricuspid. Transfemoral, you can do it transjugular, and then also, so basically those are the different ways. And we can clip we can put a clip between the posterior and septal leaflet. We can put a clip between the anterior leaflet and septal. This is much more complex now because the mitral valve, you only have the anterior and posterior leaflets, and you're putting a clip in the in between either A2 P2 junction, A3 P3, or A1 P1. But this one, you have tri-leaflet, and you're putting clips in between the different leaflets. So clinical effectiveness, just as with the mitral clip, you have patients that are post-clip that are having significant reduction in their NYHA class, going from class 4 and 3 to class 2 and 1, and their quality of life is actually much better. And so the most important trial, the Triluminate, this is the pivotal trial that brought the TriClip on the map. 450 subjects, and the evaluation of the clip looked at the clip was safe and effective. Other clips include the Edwards Pascal transcatheter clip, and this is the delivery system. So the so I'm gonna shift gears now and talk about Watchman. This is the last section of my talk. I do want to mention that the secret word number 1 is Dr. Cribier, and secret word number 2 is Kobe 8/24. So AF, atrial fibrillation, creates a thrombus in the left atrial appendage rather, that can embolize to the brain. That's why atrial fibrillation has high morbidity and mortality. Patients with atrial fibrillation are at added risk for having cardioembolic strokes. I just took care of a 95-year-old lady who stopped her blood thinners because she was falling. And 3 days later, she came with a cold leg. She had embolized a big chunk of clot from her heart to her common femoral artery. So I spent 3 hours cleaning up the clot sitting in the common femoral artery, superficial femoral artery, all the way down to the popliteal level and below the knee. We were able to suck out all the clot, and we actually put her back on blood thinners and made sure she takes them because she actually dodged the bullet there. She could have had the clot go to her brain and have a massive stroke. So the Watchman device, I want to emphasize this CHADS VAS score. This is very, very important to objectively quantitate the stroke risk per patient. So each of these, if the patient has these, gets a point. CHF, hypertension. If they are older than 75, they get 2 points. Diabetes, if they've had a prior stroke, they get 2 points. Vascular disease, age between 65 to 74, 1 point, and female sex. Now, if the CHA2DS2-VASc score is 2 or less, the risk of bleeding outweighs the risk of anticoagulation in patients. So aspirin suffices in some of these patients, unless they're 75 and older, then they should be anticoagulated. If the CHA2DS2-VASc score is 3 and above, their stroke risk is exponentially higher as the numbers go up. 3% for CHA2DS2-VASc 3, and CHA2DS2-VASc 5 is upward than 7 to 8% per year. So patients that stop taking their NOAC or their anticoagulation, they're at high risk of having cardioembolic stroke, just as my 95-year-old patient. Now, the types of appendigeal closures, the endocardial plug, the Watchman. You can also do what's called a thoracotomy and do percutaneous ligation of the appendage from the outside, such as the epicardial loop. And all of these have consistent procedural success, 95% plus. The bleeding outcomes after left atrial appendigeal closure compared to long-term warfarin. So people that are unable to tolerate long-term blood thinners, whether they're fall risk, they have coagulopathy, thrombocytopenia, they qualify for the Watchman. And the Watchman procedure itself, they have to be able to take blood thinners for 30 days with aspirin. After that, for 45 days, they take DAP therapy, aspirin and Plavix, and after that, they only take a baby aspirin. So this is the actual device. We go through the groin, do a transeptal puncture, go to the left atrium, and then deploy this device in the left atrial appendage. And when we're happy with our overall device and shape, we meet what's called pass criteria. This is with the Watchman. This is the positioning, has to be adequate. The anchor, the size and the seal. And once we meet all of those numbers, then we undo, we do 8 turns counterclockwise. We undo this and we take it out of the body. So this Watchman device itself is indicated to reduce the risk of thromboembolism from the left atrial appendage in patients with non-valvular atrial fibrillation. So this is the actual device. It has a skirt, and once we deploy this inside the left atrial appendage, this endothelializes, we have tissue development, and then it essentially walls off the left atrial appendage, so patients do not have to take blood thinners after that. This is a echo. We measure the actual depth of the appendage, and then we're able to then deploy our device. The actual the Watchman device. It looks like an apple here, or strawberry rather. And then this is a 3D view. Eventually, the tissue develops on top of this. We do have to do a sequential imaging 30 days later, make sure there's no thrombus, and the actual device is covered with unfilled tissue, and we can safely stop the blood thinners. And this is actually 9 months out. The patient, the patient has adequate endothelial development on top of the Watchman device. So let's do some questions. 3 signs of advanced aortic stenosis. A, chest pain, pedal edema, TIA. B, syncope, angina, dyspnea. C, CBA, hematochezia, hematemesis. D, thrombocytopenia, anemia, heart failure. And E, syncope, jaundice, and chest pain. Answer is B, SAD, mnemonic, syncope, angina, dyspnea. Question 2, left atrial appendage is the source of stroke / systemic embolism in what percentage of patients with non-valvular AFib? Answer is A, 90. And 2 types of MR. This is question 3. What are they? Primary degenerative MR and secondary functional MR. B, primary functional MR and secondary degenerative MR. C, primary myxomatous MR and secondary bicuspid MR. D, primary degenerative MR and secondary unicuspid MR. And E, primary functional MR and secondary tricuspid MR. Answer is A, primary degenerative MR and secondary functional MR. The slide was misplaced. It's 9A. It was the answer to question number 2. So in conclusion, aortic stenosis is a disease of the elderly, as 80% of people in their 80s have some level of aortic stenosis. However, younger people may have AS, especially with congenital deformity, such as the ones that having unicuspid or bicuspid aortic valve. Syncope, angina, and dyspnea are is mnemonic for SAD, is mnemonic as a triad for severe AS. TAVR is a percutaneous valve replacement, which decreases morbidity and mortality in patients with moderate to high surgical risk AVR. Mitral regurgitation is the highest prevalence of undertreated valvular condition. It leads to heart failure, and if untreated, 1-year mortality is about 50%. Mitral clip is the percutaneous treatment approach in patients with depressed EF, prohibited risk for mitral valve repair and replacement. Tricuspid valve pathology can be due to Epstein's anomaly, endocarditis, pacer leads across the tricuspid valve, and medications such as fenfluramine and ergotamine. These are the diet pills in the 90s, that's fen. Dyspnea, facial fullness, right upper quadrant discomfort, and bipedal edema are some of the signs of severe TR. Tricuspid clipping, although is basically approved, it shows greater improvement of symptoms in a safe fashion. Thank you very much.